This is the Health and Politics podcast.
And that's with former ministers James Bethell and myself, Steve Brine.
How are you, Steve?
Yeah, I'm not bad. Yeah. I've been busy this week and on my travels. So I'm somewhere in the Gloucestershire countryside talking to you this week. I'm here to speak at a workplace health conference, which obviously is a subject you know a little bit about. And it's called Tortworth Court in the middle of the Gloucestershire countryside. Very nice. So talking at that conference. What are you up to?
We are taking the Tobacco and Vapes Bill through the House of Lords. So we had a big vote on that yesterday, and I am pleased to tell you that it sailed through. Although 74, mainly Tories, did vote against the key Rishi Sunak generational ban element. I must admit, Steve, that surprised me. 74 is quite a hefty number.
Yeah, that doesn't surprise me that much. I mean, a lot of the MPs on the Tory side who didn't like this legislation either voted against it. I think Kemi Badenoch voted against it, actually, at second reading, didn't she? But most of those MPs who didn't like it, of course, were so-called Red Wall MPs who are no longer in the Commons. You know, at your end, there would be in Lords, there would be people who don't like it, see it as part of the sort of interventionist nanny state and just have an objection to controlling tobacco. Because, I mean, it's not been anything like that in past other tobacco control measures we've made, has it? He says sarcastically. But no, well done you. So is it finally going to get on the statute book anytime soon? Because the session is ending.
Well, it'll have to get through before the end of Parliament, which is the end of April, beginning of May. So the session is then, and then we'll have the wonderful opening of Parliament. But I will have left Parliament by then because they are kicking out the hereditaries, and I'll be free to spend more time with my podcast.
Yes, and we look forward to that very much. But we should explain that sometime, actually.
Let's do it another time.
A couple of people have said to me, you and James often refer to him leaving the House of Lords, and we should try and clear it up that you're leaving for honourable reasons, not dishonourable reasons. And people would like an explainer. People would like an explainer as to why you are leaving, and being hereditary, etc., etc. So anyway, listen, thanks for listening to this podcast. Prevention is the new cure, we call it. Every week, Jane and I sit down, we discuss, we analyse health news with the updates, the policy announcements, and we bring on experts who help us put it into context. And as you're listening on your podcast app, please, if you could hit subscribe, we'd love that, wouldn't we, James? You can get all of our episodes as they drop. Leave us a review. Obviously, 5 out of 5 would be great, but if you want to go as low as 4, and it takes all sorts, that's fine too. And if you're watching on YouTube, hello, subscribe to our channel, YouTube channel, for full episodes and the clips each week. And of course, you can find us on LinkedIn and add your comments to our coverage. Seems like quite a lot of people have been doing that since our last episode, James. We thought we'd just cover a few of them.
Yes, Steve. Daniel enjoyed our episode last week with Sarah Woolnough from the King's Fund. He wrote to us, "Great listen, as always." Thank you, Daniel. Thoughtful analysis by Sarah Woolnough and her take on prevention. Great to showcase the work of the King's Fund in advocating for evidence-based policy, of course. Sarah Woolnough said, during the show, good health is not made in hospitals. And that led Ben from Optimus Paint to comment, and I quote, "Completely agree. The biggest health interventions often happen long before a patient enters a hospital. In our work across healthcare and housing, we see growing recognition that the built environment itself is a frontline health factor. Air quality, surfaces, thermal performance, damp mold, infection transmission. Prevention isn't just behavioural or clinical, it's environmental. We'd love to see more discussion on how infrastructure and materials policy could reduce illness burden at a population scale." Wow, Steve, there's someone talking our text, isn't it?
Yeah, I think he got the memo. And I actually looked them up. Sort of a free advert, I suppose, isn't it? Optimus Paint, innovative paint for carbon neutral and wellness for sustainable and safe planet. Interior and exterior eco paints from Japan. How interesting. Yeah, I thought it's a really interesting point. So thank you for that, Ben. And just one more. Chap called Andrew reflected on the idea of prescribing dogs on the NHS, which we should just say was in relation to a story we did last week about dogs and dementia. He said, my late father was prescribed a dog by his GP in the early 1960s, so social prescribing's been around a long time. He paid for it himself, of course, he adds. He developed spinal problems as a child, which then caused heart and respiratory difficulties. His GP told him he needed to exercise regularly and suggested a dog. He lived until 85, far beyond his medical expectations, and regularly cited his twice daily dog walks as an important factor in his health. There you go. Woof, woof. So bless him. Bless Andrew for getting in touch about that. Yeah, well, we are big dog fans, of course. So, and thank you for getting in touch, Andrew. Anyway, look, what's coming up this week? There's so much GLP-1 news around this week, which the press unfairly describe as fat jabs. I don't. I'm just calling them that. So we're going to start there. GPs being paid to prescribe them more. Discuss, and we will.
The other big one, healthy life expectancy has hit a record low and the state pension age is about to go up.
Then we're going to ask, NHS leaders say prevention is turning a corner, but is it really, when new research says people are shying away from even bothering to contact their GP?
We're going to talk to the Tony Blair Institute about £26 billion prize for prevention and a major report they're publishing tomorrow on vaccine sovereignty.
Very good. And we will finish, as we always try to do, with reasons to be cheerful from your local breast screening unit this week. Before we crack on with this big show, James, we've been told off. We've been told off by a listener called Anthony, who, I have to say, fairly and squarely, between the eyes, it's fair cop. So this is what he said to us. He said, I'm a regular listener to your podcast. I was disappointed to hear that the recent episode on gambling addiction, so last week we were talking about that, weren't we, began with an advert for, wait for it, gambling. That felt inconsistent with the message of the episode. I think it's important that we practice what we preach. Well, look, I have to say, yeah, I can see your head in your hands. Look, we couldn't agree more, Anthony. We've hopefully sorted that out now via our friends at Acast who help us publish this podcast. So we've got more control over the adverts that are played at the start of our show. So look, thanks for pulling us up on it. Thanks for listening. We really appreciate it. You totally nailed it. You totally have a point. We're living and learning, aren't we, James?
We are. And despite the gambling ad snafu, we would really like it if you would hit subscribe to get our brand new episodes every week. And you can also WhatsApp us, ideally by adding a voice note so we can play it on next week's episode. And the number is, if you've got your pen and paper, 0333 404 6507.
Over the next few weeks, we're going to have various guests join us to do the health news review. And instead of just us talking about it, we're going to have some friends of ours who are going to come and talk about it. And the first one today is Charlotte Refsum, who's head of health at Tony Blair Institute, who's with us for the first part of this show. And we hope the first of our regular news reviewers to offer their perspective on what's hitting headlines in health and politics. So welcome back. Welcome back, because you've been on once before, to Charlotte Refsum. Nice to see you, Charlotte.
Hi. Thanks, Steve. Thanks, James. Nice to be here. Yeah.
Brilliant. Look, first story we're going to talk about this week, Charlotte. Story in the Sun newspaper on Tuesday, which has come out of the new GP contract negotiations. Doctors will be paid to put more patients on fat jabs under NHS plans to beat obesity. More patients are set to get weight loss injections like Wegovy and Mounjaro from their GP in the scheme. What do we think about this? Start with you, Charlotte.
Well, as you can imagine, I have views.
Always.
Tony Blair Institute has written about this topic before, about GLP-1s. I mean, they are such a huge opportunity, and particularly for prevention. So we know that obesity drives lots of the conditions that keep people out of work and shortens their health span. So we all know about the impact of obesity on cardiovascular disease, but also it impacts joint and muscular problems because through weight, mental health problems, lots of the things that keep people out of work. So I think there's a huge opportunity with GLP-1s, which I think the health service honestly ducked. They had an opportunity to roll these out quite widely, and NICE reviewed them and said they were huge value for money. It was NHS England that pulled the ripcord and said we can't afford it. What I find weird about this is that there are so it's a huge opportunity. I don't actually have a problem with paying for a service to prescribe and manage them. I just don't know why they've asked the GPs to do it, because they are sort of busy enough already. Why don't they do a sort of a national tie-up with one of the big pharmacies like Boots or Asda, or and get them to do it? Doing it through GP is probably one of the least sort of cost-effective and efficient ways of doing it. And quite frankly, there's about 2.5 million people on these jabs already in the UK, and they're not getting them through their GP. They're getting them online. And it's been shown now that there are fast and effective and cheaper ways of doing it. So I don't object to paying for a service to do it. I just don't know why we're paying GPs to do it.
Yeah, it's a bit unimaginative, isn't it? What do we reckon, James?
I completely agree with Charlotte. It's probably more than 2.5 million, maybe nearer 3.5 million doing it privately. Asynchronous prescriptions, support on a digital platform, off-ramps if you feel poorly. But it seems to be working in the private sector. And yet we're going to go to GPs first. And I would flag that GPs don't have a great track record at talking to people about challenges of obesity. It's not really their comfort zone, that kind of intervention. So yeah, it does seem a real shame, and creating an expectation that there's going to be some generous kind of involvement of GPs, but actually it's just creating a bottleneck. The latest projections are that a year's worth of GLP-1s will be £250 per person. Because once we switch from syringes to tablets, that brings down the cost per unit massively, and the digital platforms are reduced enormously. But you then add in a GP appointment, well, that immediately is what, £49. If it's one GP, you're probably doing 4. So you're kind of like doubling the cost of the whole exercise and inserting a resource of which you've got very little capacity. So I think this will be good for a very small specialist number of instances where a GP would like to be able to prescribe a GLP-1 on top of other things. But the idea that this can be the funnel through which we do the mass population distribution of this important drug to millions of people, no way, that ain't going to happen.
No, I mean, it needs to be part of a weight loss pathway, doesn't it? And that's it needs to be part of a service that helps people to lose weight, of which GLP-1 is a part. And that's something that GPs, will be unable to do.
Yeah, that's right.
I worry, though, that it's even worse than that. I worry that it's sort of basically showboating, because, I heard a really eloquent GP I was driving my son to his early morning, by which I mean early morning school cricket at 6:30 on Tuesday morning. And I heard this GP in London on the radio, and she was saying, look, they'd love to prescribe more GLP-1s, but they're prevented from doing so by the medicines budget, that their ICB allows them to prescribe. And her point was, instead of this sort of headline initiative to put the money into GPs to prescribe, which is actually partly their job anyway, put the money into the prescribing budget. And she also made the point, which I thought was really interesting, that patients often present her with a dilemma that they feel they face, which is that they have to put on a few pounds in order to qualify for meds to be available to them on the NHS. I mean, that's just insanity, isn't it?
Yeah. Well, it's just we've rolled them out in they are limited, and they're being rationed, and they're being metered out to the people who have the greatest, that have the most weight. But part of what we looked at in our paper was where you could more effectively target that spending, and actually spending this money on people who have 3 or 4 comorbidities and have a weight problem and all these other things. Like you're reaching them right at the end of that pathway, when actually helping people who are earlier on in the process can be more effective. It's particularly effective if you're looking for an ROI on your economy. So that was part of our research, was that actually investing in prevention is good for the economy because it keeps people in work longer. But that maths only works if you're giving it to the working age population. If you're giving it to people who are already out of work or no chance of going back into the workforce, it doesn't make sense. So it just gets to the sort of the insanity, really, of the fact that we're reaching people far too late, and then we can't have this amazing drug that could be an intervention very early, a preventative intervention, and we don't use it as such. We use it as a late stage intervention.
The early stage intervention is very cheap. If you do it on a digital platform with I mean, not with a great big wraparound service of psychological support and physiotherapy and oncology and what have you, if it's literally an intervention on someone who is clearly heading towards disease in their 30s or 40s, and you can modify the risk massively for £250
Yeah.
and save yourself what, 100,000, 500,000 if they're going to go on dialysis.
It-
Boy, oh boy! I mean, it does not take a Scottish accountant to figure that out. Excuse me, Callum. It really doesn't. It is a cultural resistance to actually believing that early intervention will make any difference.
Can I just make a point? Because I thought this was really interesting. Late last year, I was speaking to Leslie Regan, who's president of the Royal College of Obstetricians and Gynecologists, and her point was that one of the biggest expenses within the NHS is NHS resolution, which is payments made for mishaps and the biggest spend within that is on accidents that occur at birth. And she said the one risk factor that is common throughout almost all of those, the major complication is a high BMI in the mum.
Really? I didn't know that. That's very interesting.
And like a really high BMI, like sort of over 45 sort of BMI.
Gosh, that's very interesting indeed.
And what I find so profoundly disappointing is that we're metering these things out in a really kind of miserly way and giving it to people who are sort of at the end of the stage, rather than saying, actually, there's a cohort of young women who are about to enter, of childbearing age and working age and all of these things, and we're about to, condemn them to a life of complication.
Yeah, totally. For the amount that we spend through NHS resolution on those maternity payouts, which can be 1, 2, 3, 5, 10 million pounds, you could literally put almost all young women on who needed it on preventative measures.
Supporting women who are of childbearing age, so maybe they're not even actively thinking about having a baby, but they're of childbearing age, and supporting them with weight management services and proactively helping them, so that but nobody thinks like that.
Yeah, well, look, if ministers thought this was going to please the GPs, then I'm not sure it has done that trick either, because the Royal College GPs said, let's get this straight, GPs don't withhold treatment or prescribe based on financial incentives. Decisions are guided by clinical judgment and what is safe and the most appropriate for individual patients. And, ouch. Look, another story kicking around. Healthy life expectancy in England has fallen to 60.9 years for men and 61.3 for women, the lowest since records began. James, you spotted this story, this data, wasn't it, that came out last week?
It's just the biggest story in a busy week, this should be on the front page of every single paper. It is heartbreaking on a personal basis. It's a massive social injustice, because that curve is really being brought down by the bottom half of the deciles. The wealthy, the Buckinghamshire and the prosperous are not bringing that curve down. It is people who live in deprivation and difficult circumstances. But most of all, and I hate to sound hard-nosed about it, but this is really the point, it's devastating for our economy, because these are people who are going to drop out of work and then be on welfare for 20 years. And that will cost taxpayers, of which we don't have very many left, a fortune. It will be lost productivity. Ironically, many of them don't cost the NHS a huge amount, because spending 20 years sitting on the sofa, dropping into the GP every couple of years and having some statins or whatever doesn't actually cost the NHS a huge amount of money. It is the welfare and the lost productivity that is economically disastrous, and the shared care, because often these people, if they become poorly, then need someone else to look after them. So this curve desperately needs to start pointing upwards. We are going to bankrupt the nation. My children will not be able to afford to live in Britain if we don't change this trajectory. And it is unusual. Most other countries don't have this problem in the way that we do. In fact, plenty of countries are getting better healthy longevity. It is a particularly bad, we're not the only ones, but it is a particularly bad British disease. And if you want to ask me about what the causes are, let's do a podcast on it.
Multitudinal, I believe is the word. I mean, I think this is going to really alarm the Labour government. I think it'll sit very uncomfortably with a lot of Labour MPs. There's lots to talk, isn't there, in the media about what is this government for? Who is it for? Surely, if it's for anything as a Labour government, it's to tackle inequalities like this and to close that gap. I remember a conversation I had with a Labour MP, now a very senior minister, at the back end of the last parliament, when obviously they were on the opposition benches. And they were telling me how, at the end of the first term of a Labour government, inequalities, that would have narrowed considerably. And that's what they're about. And I said, you know what? It'll depend on what you do. He said to me, okay, that's narrowed it down by 50%. If we haven't done that, then it's an absolute head in hands time, and we will have failed. So I think it will set alarm bells ringing in Downing Street. This story, as you say, it should be a lot nearer the front pages than it is. What do you think, Charlotte?
The welfare point is interesting because we've been thinking about this a little bit inside the Institute as well, and we have been looking at we did a piece last year called Mental Health Data Decoded, and looking at trends particularly in mental health and the sorts of conditions that are driving up welfare spending. And what was interesting was the country comparators. So while the UK is not an outlier in terms of the incidence of these conditions, so depression, anxiety, and other things, we are an outlier in the extent to which we support those people not to work, and we are particularly poor at supporting people with those conditions to remain in work and or to get back into work if they are out of work. And so that's been a sort of focus of some new work we've been doing recently to think. And of course, Charlie Mayfield had his review earlier this year, was looking at exactly this. Mainly his perspective was on the employers and how you encourage employers to retain people who have mental health problems and identify problems early and support them. The focus of our work is really on how people who are out of work, how you get them sort of back in. But it's fascinating. There's a real I'm going to tell you an interesting story that I heard, because as part of the work, I started talking to Simon Wesley. Do you know him? Yeah. And
we had him on the show, yeah.
Did you? He told me such a fascinating story about how you retain people in work when they're going through mental health problems. And he gave the example of the tube workers. And he said that quite often on the underground, it's not you quite often get fatalities on the track, and it can be really, really distressing for the people who are driving the train when that happens. And they used to have a policy of sending people home for like 2 weeks. Oh, take some time off, absolutely do. And it was disastrous for their mental health, actually. And what they needed at exactly that point was to talk to people that knew exactly what it was like to drive a train, and knew exactly what it was like to have gone through an experience like that. And they pivoted their approach so that they didn't tell people to go home. They said, come into work, but you don't have to drive a train. You can come and do, light duties, as it were. And then when they reintroduced them back into driving, they would sit in the cabin, but they wouldn't drive. They would just sit with somebody else who did the driving. And then after a while, they'd be so sick of watching somebody else do it, they'd be like, I can take over. But it's about this idea that cutting people off from work at exactly the point when you need that social network to support you through mental health problems is exactly the wrong thing to do. And I thought that was a really fascinating example.
Yeah. You're listening to Prevention is the New Cure. It's the Health and Politics podcast with myself. I'm Steve Brine, former Health Minister, former Chair of the Select Committee, and Lord James Bethell, who's also former Health Minister. And we're joined this week for our news review by Charlotte Refsum, who's Head of Health at Tony Blair Institute. James, what's next?
Well, there's an interesting report by PA. I happen to know the team there. I think they're pretty good. And they've just put a spotlight on this strange gulf we have, that the technology around prevention, particularly on things like at-home diagnostics, but also things like population screening, are at the most promising and exciting that they've ever been in history. And public attitudes to them are the most progressive and sympathetic and interested. But somehow they're just not getting through to the patients and to the people. Politically, 8 out of 10 people think that digital tools could reduce health inequalities. And many doctors, 77%, would like to see ring-fenced multi-year funding. But no one, literally zero respondents to their survey, felt that health tech was being supported by national bodies to scale innovations locally. And that is absolutely my experience dealing as I do with health tech companies. It is a massive struggle. I know all entrepreneurs are super excited about their product, but I can't help feeling that I am seeing really thoughtful, exciting new prevention technologies almost every day of the week. And the battle stories they tell of trying to get in one contract, one door, one little scraping pilot, and let alone trying to scale it across the whole system. It's really stuck, Steve. It's really stuck.
Charlotte, you know a lot about this. 33.6 million people are on the NHS app now. This simples, yes? Sorted. Should all be sorted.
Yeah. Well, funnily enough, we wrote a paper about this as well.
I know you did.
Yes. So the thing about the app is that it needs to be relentlessly consumer focused. And that's what I think is just slightly missing at the moment. It still feels like it's there for the system. Maybe it's trying to shift demand, or it's trying to move people here, but it's all about the system. It's not really about meeting people where they are and what their needs are and so I think that starting from the point of view of the user and what they want is a good start. And I also think that we recommended that as part of that, they should have a prevention offer within the app. And it should be, there's so many things you can do through it, and it needs a nationalised approach. Even if some of the delivery is local, I think that there's a thing about having an app is that you can scale things very, very quickly. So you could just do a deal with, one or two different pieces of technology companies, and suddenly you've got something to roll out to the whole of the population. It just seems such an easy win. So I think there is a lot of potential with the app, but at the moment it still feels a bit like it's for the service rather than for the user.
So that's so true, isn't it? If the Amazon app logged me out as many times as the NHS app does, I certainly wouldn't be using the Amazon app. And that's where it is, though, isn't it? I mean, 33.6 million people are on the app, but are they really, or do they just have it downloaded? Because I have it. I'm a former health minister, and I like to think I'm reasonably savvy on these things, health and tech, but I just find the thing completely muddling. Am I being Luddite, James? You're better at this than we are.
Steve, I would prefer you didn't ask me that question. No, I use it the whole time. I have my children on it as well.
Right.
And it's not great, but it's not that bad. And the Barclays app isn't very good either. So I think it just about passes muster. I mean, I completely agree with Charlotte's point that it does feel like it's there for the convenience of the NHS Tech community rather than actually for consumers. But the other key point about it is not open to any other participants. It really is a closed shop. And my Apple phone would be no good if there wasn't an app store where I could access other things and use the information that was on my phone for those other things. I want to tell you, I met Victoria Hornby, who I was at university with, who's fantastic and runs mental health innovations. And their main thing is a suicide prevention digital platform. And when I was minister during COVID, we were very worried that during COVID, people who had psychological or suicidal thoughts might not be able to access GPs. What emerged is that they preferred to interact on Zoom. They didn't want to go to a GP surgery or to some horrible clinic. They liked the buffer. And the suicide prevention people have taken that further, and they now have AI and text. And there are some people, mainly men, who prefer talking to an AI bot about their suicidal thoughts than they do a person, because it's more reasonable for them. But she cannot get it on the app or anywhere near the NHS platform. It all has to be done on ICB negotiation with ICB negotiation. It has to be tailored to this sort of Nether Wallop suicide prevention service. It is so painful. And there's 4,000 people committing suicide a year in the UK at the moment. Quite a lot of them I mean, a proportion, 10% for sure, could be headed off if we gave them a really good public national service. But the tech platform hasn't kept up.
Charlotte, the point you made about it being effectively there for the system, or feeling like it's there for the system, feeling like it's there for the providers, sort of to remind, this is one other story that, before we talk to you some more about some TV, the story I spotted this week, that new research from the Health Foundation and Ipsos show that access challenges are stopping people from contacting their GP. So they conducted this research in December 2025. Half the public, 40%, delayed or avoided contacting their GP practice about a health concern in the previous 12 months. So I saw some YouGov research just today, actually, which had how well do people in the country think the government are handling, and then it listed all the different areas of policy. NHS is on a -50 right now. There has to be a connection between those two things. I was also ranting on the show last week, Charlotte, about how when you phone your GP, it's very much, it has to be at the time that it suits them and in the way that it suits them, with, one hand in the air, wearing a brown cap. And, so that feels like it's sort of provider-led, not patient-led as well. And all of this is all linked to the new GP contract, of course, where they're going to guarantee you same-day access for urgent care, define urgent care. So did you see that story about people not actually bothering to contact the GP because just like, I'm going to be blocked? Did you see that? I mean, that's got to concern us.
Yeah, I did, but it doesn't surprise me, because I think people have already started to circumnavigate a service that doesn't work for them anymore. And I say that as somebody who used to be a GP, and I couldn't, honestly couldn't believe it sometimes. It felt antediluvian, that model, and it felt like I say this all the time, so stop me if you've heard this one before, but no, I was practicing medicine in a converted bedroom in a semi-detached house in a suburb of southeast London, with no access to any same-day bloods or ECGs, or I mean, it was, and it just felt like, and I honestly had little laminated sign next to my desk that said, "You have 10 minutes to talk about one problem." In our era of multi-complex, complexity, it's totally baffling. So it doesn't really surprise me that people are circumnavigating. The other thing that they're doing is they are using things like ChatGPT and Claude, because they know it's not 100%, but they don't mind. It doesn't really matter. They just want a bit of advice and a bit of support. Do I need to go to A&E? Do I need a GP appointment? What should I do about this? I think that will start to increase and increase. And actually, I was thinking recently about what would happen if you started to use. So obviously, that Anthropic and OpenAI have just launched their own health products, which is essentially, I think they still use the same model. It's just what they give you is a secure data environment for your data, so the data doesn't leave or go anywhere, and it doesn't go back into
I think the
training
stack
model.
they've got a different. They're using a stack with registered medical advice in it rather than kooky stuff.
Could you imagine if you were using that, you're finding it very helpful, and over time it gets to know you, and you'd never have to repeat your story. It always knows.
That's what I do.
Exactly what. And then over time, because it's so useful, people would just throw data at it. They would consume this data. You could even if EMIS refused to join up with it, you could take a readout from your GP, feed it in, and then suddenly it's got your whole GP history as well. And by then, it becomes, in a way, like the de facto single patient record. You've created
Charlotte, you're so behind, I'm afraid, on this. So I've taken all my bloods for the last 5 years, all my biome, my DNA, my genomics, my Strava, my Whoop, and I dropped it all into a space on my Perplexity, and then interrogated the hell out of it, and said, ask it questions. Pretend you're Charlotte Refsum, the local GP. What would you make of this? And it gave me a 43-page report on the implications of my genomics, how it's played out into my bloods, and what my current status is. And it was absolutely fascinating. Yeah. I sent the 43-page report to my GP and said, I'd love to meet you to go through this. And do you know what, Charlotte? He hasn't phoned me back. I'm really surprised. Could you explain this to me? I'm really confused.
sitting in a semi-detached house with no access to bloods, and then what you've just described is so stark. Just people life has moved on, but the GP model just has not moved on. It is just crazy. It absolutely doesn't surprise me that people are now circumnavigating.
I'll take a minute before we have to move on, but can I just read out the statement from Victoria Torres-Brown, the chair of the Royal College of GPs? She says, with a straight face, general practice is the front door of the health service, and patients should be able to see their GP when they need to. So it is worrying to hear that some might be delaying or avoiding seeking care because they think getting an appointment will be difficult. There we go. That's reassured all of us. It's all going to be okay.
Yeah. I mean, there's so many AI health docs. I mean, the future is basically, isn't it, AI that knows more about your body than any human ever could.
It will be able to risk stratify you far better than any NHS, because we're relying on, everything that's coded. But these things will know not just your coded conditions, but it will know that you had sniffles the last week and that your children were ill 2 weeks ago. But it can read all the PDFs. Yeah.
So all the lab reports that are completely impenetrable, it can read them. I mean, even my GP finds it a struggle to find the flipping blood report. I'm not.
If I said to it, it's live before I go on my summer holiday, can you deal with a dad bod? It won't be able to fix that, will it? Hey, there you go. There you go, Charlotte. You can have that one free. Listen, Charlotte, before we let you go, we thought we just would talk to you about the prevention prize, which James and I spotted, and also you're doing a big report tomorrow in Parliament Day, actually, as this podcast drops, on vaccine sovereignty. So James is actually hosting you, so you'll be back together today. James, over to you.
Well, no, well, vaccines exercise me a lot. I'm chairing the Royal Society of Public Health Commission on vaccine access. And that's what bugs me. There's a lot of talk about vaccine misinformation. For me personally, here in the UK, our big challenge is access. But and I'm going to talk, Steve, if you don't mind, at length about that. Maybe we can get JVT on the show and get him to talk about that. But Charlotte, tell me about your report.
Yeah. So it's a slightly different lens on it, actually, and I'd be interested to know what you think. So it's looking at the concept of vaccine sovereignty. So it's basically sort of arguing that, well, I didn't know this, but vaccines have a very global provenance. They often cross borders multiple times in their development.
Yeah.
And the ingredient, the sort of supply chain.
Tell me about it. You bet.
Ingredients is,
all the glass comes from Italy. All that, I know, it's a nightmare.
But also, I was really interested to know the extent to which we are dependent on countries like China for mRNA ingredients and things like that. So it creates these kind of dependencies which are exposed in times of crisis. But I think even more now, with sort of the moving global geopolitics and increased tariffs and conflicts and all these other things actually start to threaten vaccines during normal times as well, not just during pandemics. And so the point of the paper really is that we should be viewing the ability to make vaccines domestically at home and pivot production to whatever you need. It should be considered a national security issue. And because if you think about it as paying like an insurance that you're paying to be able for resilience for when you need it. And we actually took this paper to the Munich Defence Conference a couple of weeks ago to discuss it with some bio experts. And I'm used to going to health conferences, and the defence conferences are very, very different. But I thought it was really interesting speaking to those experts, because they were saying that with the shifting geopolitics, we should no longer be thinking about national security as narrowly about defence. It needs to be about, they were saying things like, well, actually, energy security is national security, food security is national security, and health security is national security. It's you're paying to ensure your entire economy so that it doesn't completely shut down while you're dealing with a pandemic. So really, really fascinating. I've been working with Jonathan Van Tam on that, who's written the foreword and will be at the event later. and you should absolutely get him on your show, because he is as lovely as he looks on the TV, and he is fond of a football analogy. So
He's very good at
it's good
those.
value. Yeah.
Yeah, and we both worked with him in government, and great fans of Jonathan Van Tam. So yeah, we might just get him on. And I see you've got Dr. Zubir Ahmed, who is the Parliamentary Secretary for Health, Innovation and Safety at the event today. He seems to be. I hear good things about Zubir.
Yeah,
I
me
think
too.
he's good. I
He's
think
great.
he's a thinker, and whatever happens with the ministerial merry-go-round, I hope he stays in his role for this Parliament. He's a new MP. He was only elected in 2024 from Scotland. I think he's one of the Glasgow MPs, but he seems to me to be a thinker. So have you had positive engagement with him, Charlotte, and indications that he gets this agenda?
Oh, absolutely. No, he's great. I love Subir. And he's also a renal transplant surgeon. Did you know that?
Oh,
Yeah.
right.
No,
Like Steve Powers.
Oh, yes, yes. No, he totally gets it, and has been very supportive. But it'd be interesting to speak to him at the event, actually, about how government is viewing this issue of resilience and national security.
Well, I mean, I think that's right. We're facing a completely different world.
Yeah.
When Carney gave that amazing speech, he did say we have to be looking after our food, our fuel, and our energy. He should have also said health. And we found in the pandemic, we're totally reliant on countries around the world. We had no ability to look after ourselves. Couldn't even make a flipping gown. So yeah, I think health resilience is going to get back on the agenda, even if a lot of people give some slight PTSD to remember it all.
Yeah,
Presumably,
absolutely.
Charlotte, once the reports launch later on, you can find that on the Tony Blair Institute website.
Yeah, absolutely. Yeah,
And on
normal
socials.
channels.
Charlotte, it's been an absolute pleasure having you on the podcast with us. Thanks for putting up with us and going through the news stories of the week. We really enjoyed your input, and good luck with the event that you and James are doing later on today.
Thanks so much.
Thanks, Charlotte.
Yeah, welcome back. This is Health and Politics podcast. Prevention is the new cure. There goes Charlotte James. She's always good fun and really interesting to get her reflections on the stories of the week, and also talk about stuff that TBI are up to. What did you take away from that?
Well, I like what TBI are trying to do. They are optimists. They're positive. They believe in the prevention mission instinctively. They think that we can bend the disease curve and improve the underlying health of the nation. But I'm afraid I don't think they've got the ear of government right now. I don't get the feeling that government is buying that. It is totally ploughed into the producer interest and trying to manage that as effectively and the old playbook of trying to minimize strikes and squeezing out more efficiency.
Yeah, I fear you may be right. I mean, you know what government are like. Once you get on the wrong side of them, they stop talking to you. And if you do remember a year or so ago, Tony Blair out something around government and net zero, which he then very quickly had to row back on, presumably because Number 10 asked him to. And I just wonder if there's been a little bit of a frosting over of relations between Blair and this Downing Street, who, I don't know what Blair's view is of Starmer, but if I was Starmer, I'd be taking him under my wing and trying to get his help, because he did actually win 3 general elections. But the other thing that I thought was really interesting was Charlotte. Whenever we talked to her, we had a podcast a year or so ago. Sarah was with me, and you and I have talked to her about this privately before. The NHS should think like an insurer, and actually, when you think about it, it's literally called national insurance, the tax that we don't hypothecate, but is in theory what's used to fund the NHS. And if you think about the way that insurance and health insurance firms work, is they are trying to, like the conference I'm speaking at tomorrow, their whole business is to keep you healthy, and so that it reduces the liability that they have. The state should think exactly the same, is basically Charlotte and TBI's point. And they're always, I think, trying to answer the question as to why it doesn't and how it could. And that makes a lot of sense to me. Whether, as you've said to me before, whether it would survive first contact with the Daily Mail, I don't know. I think increasingly the public are in a place where they're being asked to pay more and more and then more for the NHS. And I just wonder whether they're asked to pay more tax for a service that they don't see the outcomes they want, and whether they are willing to have a more intelligent conversation.
I think it's much worse than that. I think that a lot of the public, I mean, obviously there's no such thing as the public, but quite a lot of people have had such problems not getting the access, not getting the support. National insurance went up 2%. We were promised improvement. Nothing's come through, really. The doctors are striking like mad, getting pay rises that normal people have never aren't seeing. I think that there is a good chance the NHS may go like the Metropolitan Police to becoming one of these institutions that actually has quite an electric effect with the public and really loses trust. It's on a knife edge at the moment, I think.
Yeah, yes, you're right. Was it Churchill who said there's no such thing as public opinion, there's only published opinion, which I suppose you should always remember in the light of the minus 50% story as to what the public view this government and health. But before we close, thanks so much for listening to the podcast. Reasons to be cheerful, James. Breast screening, it's a 10-year high.
That's right, Steve. Listen, there's lots that I could say that frustrates me about what's going on in prevention, but let's please celebrate the good things. Breast screening, one of the very original mass population screening programs, has become more and more refined, more thoughtful, more risk orientated, and bringing new technologies and new engagement into it. And the result is great. It is the attendance figures are, as you say, 9.4 million women aged 50 to 70 attended within 6 months of invitation. That's up nearly 200,000 from the previous year. Well, that's great. That's a lot of disease avoided.
What do you think drove it?
I think just stamina, just trying to grind out, making it better. And also making sure that people had confidence that when they were called, it was for a good reason. And therefore, this prioritization point, which is the essence of personal public health, is really important. It's not just that you don't waste the cost of a scan on someone who doesn't really need it. It's that the person, when they turn up, has a confidence that you've called them not because you were moving on to the next letter in the alphabet, but because you'd had a good look at their profile, their genomics, their age, their location, their history, their family, and you'd said, you know what, you should get a scan.
Yeah, no, I agree. And bottom line is, as I was the minister responsible for the programme for a number of years, breast screening works. It's
really does.
simple, and it's a model that works. As somebody who lost their mother to breast cancer,
Steve, I didn't know.
And in the breast screening program, and it saves lives. And I always worry when I hear clinicians argue that we're over screening, leading to over treating.
I know.
And it's one of the big national screening programs alongside cervical, and of course the bowel cancer screening program, which we talked about a few weeks ago, James, because you were sent your bowel cancer screening program kit, and I happily received mine. Yes. Which, as the minister who commissioned this kit, I put out a tweet which said, I'm not sure if proud is the word, but I allowed myself a little smile as this kit arrived in the post. And I should just tell our listeners of Lord Bethell's response to me, you should be proud. I was certainly thinking of you as I spooned into the diagnostic cup. Well, thank you for that visual image, Lord Bethell.
There we go, Steve.
I
really was. Steve would be so proud of me right now.
Don't forget, you can email us, prevention is the new cure podcast @gmail.com. WhatsApp us, as James said earlier, 0333 404 6507. James, I'll see you next week.
Steve, it's been really good broadcasting with you. See you next week.
It's been great fun.